Hi, Sian. Thanks for talking to me today. Can I just ask you to introduce yourself?
Yeah, my name's Sian Jones. I'm a GP in Inverness, and I'm the primary care clinical lead for cancer and palliative care in NHS Highland.
Today we're talking about the Gynaecology Referral Guidelines. Can you tell me what the major changes are?
I think the biggest change in the new 2025 guidelines is new guidance on unscheduled bleeding for patients on HRT. As you'll be well aware, since our last guidelines were published, there's been a huge increase in the number of women taking HRT. So now the new guidelines will signpost you directly to the British Menopause Society website, to a section with really clear and concise guidance on what to do when people present with unscheduled bleeding. There's also been a slight change in the format of the guidelines. So we now have a clinical assessment section. This section gives good tips for clinical features to look out for, guidance for investigations that can be taken place in primary care. There's also been some updated data surrounding demographic trends and prevalence and things like that for the different gynecological tumour types.
So I know some of the other guidelines cover risk factors that you want people to consider. Is that included in the gynecological cancer?
Yes, to a certain extent. It's covered in the key information section. Probably the biggest change will be signposting to the risk factors for endometrial cancer. Again, these can be found on the British Menopause Society website. So again, there's signposting to these guidelines with regard to the major and minor risk factors that they talk about in their flowchart with regard to unscheduled bleeding on HRT. I think the other thing that has been highlighted in the new guidelines is the importance of family history in ovarian cancer. And also they've highlighted the difference between cervical screening and investigations when someone is presenting with symptoms compatible with cervical cancer, and to differentiate when it is and when it's not appropriate to do a smear.
I know the guidelines are split into assessment and referral advice. What are the specific things that are covered in this?
Probably one of the biggest things that they wanted to get across in the assessment section is the need for clinical examination, both abdominal and pelvic. And I think to just re-emphasize the importance of doing a clinical examination and not just jumping straight to the investigations. The other thing, of course, particularly for ovarian cancer, is that it can present in such a vague way. It's helpful to have a reminder to sort of keep ovarian cancer in mind, even when you're presented with colorectal type symptoms or urinary symptoms, as well as pelvic symptoms.
And I know one of the significant new parts of the guidelines as well is the good practice points. What's included in that?
In the good practice points, that's actually where we cover the issue of doing a CA125 and an ultrasound at the same time at the outset if you have any suspicion of ovarian cancer at all. It does suggest that the most sensitive investigation is transvaginal ultrasound. And I think that's important if you need to specifically request that in your health board. If it's important that you specify which one you want, that's the one that you need to be requesting. And of course, it's a good reminder to advise ladies that that might be what they have to have as well, because sometimes it can come as a bit of a shock. I think ovarian cancer is not the only thing that can cause a raised CA125. There are other things that can cause that as well. And there's another link to other things that can cause a raised CA125, particularly things like menstrual bleeding. So trying to avoid taking the test at that time. The other, on sort of, I suppose, converse to that, it's also highlighting that a normal CA125 is not always reassuring, and that there's a significant number of ovarian cancers don't have a raised CA125. And also, I believe that the CA125 goes up as the cancer progresses. So there's, again, a significant proportion of stage 1 ovarian cancers which won't have a raised CA125. So again, if we're trying to sort of detect these things early, that's why they're highlighting the importance of doing both at the same time, the ultrasound and the CA125. The other thing that is covered in the good practice points is for us not to forget trans men who may still have gynecological organs. So not to forget, if when trans men present with symptoms that could be compatible with a gynecological cancer.